Good afternoon to all of you. As most of the people here speak Spanish, I will speak in Spanish. I am Ligia Giovanella. I'm a professor, researcher by the National Health School of Fundação Oswaldo, Cruz, Rio de Janeiro, Brazil. We will speak today about the challenges, current challenges of the health systems, specifically speaking about the health service systems. Today, the health systems have common challenges resulting of financial restrictions and the increase of expenses, of changes in the demand for demographic dynamisms and epidemiological ones, the aging of the population, chronic non-communicable diseases, and also multi-morbidity, the need of changes in the assistance model, and the strengthening of the primary health attention with the development of labor strength and health to respond to these new demands. Technological changes that will allow new services and the development of the ICTs that facilitate communication. We have additional challenges for the systems of Latin America and the Caribbean to ensure the human right to universal access to the health services. These additional challenges are a result of social shortages in our region, as poverty, deep inequality and social exclusion, and also specific traits of our health systems. To speak about the challenges of the health systems, we will start identifying the main traits of the health systems in Latin America and the Caribbean that are segmentation of social protection and populational coverage, privatization in the funding and the service rendering, the challenge, and also the issues of organization and also organization fragmentation that challenges the efficiency and coordination of the necessary cares to face the new epidemiological demands. In the greater amount of the countries of Latin America and Caribbean, we can see a great segmentation in the social protection and health, with the presence of several subsystems with different rules of funding, affiliation, access to services and services networks that are responsible for the attention to health in different population groups according to their labor status, social belongings, and payments. In the great amount of the countries, we can observe four main segments of coverage with different combinations, depending on the history and the political and social struggles in each country. The first segment is a social insurance that covers groups of average income included in the formal market of work, with contribution of the workers and the employers that cover in general only 20 or 30% of the population, considering that the informal labor system is quite high in our region. As you can see in this graph, the population that is affiliated to the Social Security, in average, reaches only 46% of the occupied working class, as you can see in the yellow bar. In this case, the exception is Costa Rica, where the Social Security of Costa Rica covers with social services the whole population. Another segment is the public health system with partial coverage to low-income population, by direct coverage, and here the exception is Brazil, that was a single health system created in 1988, covers formally all the population, 100% of the population. However, 25% has an additional coverage of prepaid supplementary medicine. Another segment of coverage is a coverage of selected packages by public insurance focused in specific groups like maternity, children, elderly people, or low-income people implemented since the 90s. The exception here is enhanced in the case of Mexico, with the popular insurance for health has increased the population coverage, although they haven't broken the segmentation. Another segment are the private health insurance or prepaid medicine that cover greater income groups in great amount of countries, and the own payment that affects all the groups and segments, and the exclusion of health that can be very high and is multidimensional. This table here shows the segmentation of the systems in health with the example of countries in South America and a study performed by the South American Institute, ISAGS. The crosses mean the coverage of the population, the proportion of the coverage by each of the segments. Considering the funding look, the coverage in health in our countries is strongly privatized. The public funding is insufficient, and there is a predominance of private expenses. As you can see in this table, the public expenses in health as a percentage of the GDP doesn't reach 5%. In countries that have reached universal coverage, like Costa Rica, for example, or Canada, the participation of the public expenses in the total of the health expenses more than 7%. Moreover, the public expenses in health with the participation of the whole expenses in health is very low. In the great amount of the countries, it doesn't reach 50 or 60%. Countries that reach or have universal coverage in health, in general, their expenses in health are over 70%. In the public, expenses are over 70% of the whole expense, like here, Canada or Costa Rica, for example. And in European countries, it reaches a participation of up to 80% or more, like the case of England or Sweden. One obstacle to advance in this universal coverage and to increase the public funding is the low taxation load and also the low collection with high taxation in our region. This is a challenge that is additional to universality and equality. As you can see this table, in Latin American countries and the Caribbean, most of the 50% of the taxation is constituted by services, while in OECD countries, this represents 31%. One trait of this way of collection is that the taxation on consumption have very regressive traits because they cover any kind of population, low and high income population. The poor people relatively pay more taxes than the rich people. The segmentation and the privatization are obstacles that are very important to reach universality with equity. It is necessary to advance in 3 dimensions of universality: in the coverage of the population by the public system, in the deepness of this coverage of this service package, and the level of coverage of the public funding. To advance in the assurance of universality of access of integral care with equity, we have to face the segmentation and to increase the public funding to improve the capability of collecting taxes in the states and having taxing systems more progressive and reaching a greater fiscal justice. Additional obstacle is also the deep inequality in social systems in our country. We can see an important concentration of income, as you can observe in this graph. And from 1 to 4, that means 40% of the most poor countries detain only 15% of the income. As you can see on the lower part here, that the bars that are blue, dark blue. And from 10 in pink are 10% richer ones that detain 32% of the incomes. So when we have the health public policies in our region, we have to always bear in mind that it's necessary to produce the redistribution in order to reduce inequality, socially speaking, in health. These social inequalities are reflected in inequalities in the health situation, in the access to health services. Therefore, we have elevated concentration, although we have reduced social inequalities, as it is shown in the graph with the variation of the Gini index in the last years. Another phase of the segmentation is the fragmentation, with a lack of coordination among public institutions of social security and private assistance, and also the existence of many entities not integrated in each subsystem. This results in a lack of integration of the assistance network, a lack of coordination among different levels of attention to health, what affects in an unfavorable way the continuity of the care and avoids the assurance of integral attention. The organizational fragmentation reduces efficiency and makes it difficult the coordination that is necessary to respond to demographic changes and epidemiological ones and ensure integral care and insurance for chronic diseases and also multimorbidity. There is a requirement to changes in the attentional model with the strengthening of primary attention to health. The changes in the demand new assistance models to ensure integral care. It is necessary to change from service systems organized to give a response to acute diseases to systems that may respond to chronic conditions. The chronic diseases to be faced, we require very complex responses for a long period of time with the simultaneous use of complex services which require a coordination of multiple professional actions in health, of inputs, medicine, and also monitoring equipment, besides the promotion of active participation of the patient. The coordination of the care is today a challenge for all the health systems. But how can we obtain a better coordination of these services through continuous care that people with chronic non-communicable diseases require? Coordination is a central attribute of primary attention. We need multi-professional teams in amplifying clinical action at first level, improving in the quality and capability of resolutions at this level, an important function of nursing in the coordination and the follow-up of chronic disease. In the renovation processes and primary attention countries, we can see some changes in this model of attention to ensure integral care. Multi-professional teams focus in the family and communities, population-defined territories, integral networks for health services, and also including knowledge and health practices in original people with great participation in the intercultural aspect, promoting health with intersectoral action to face the social determinants and also the promotion of the social participation. Another important challenge is the development of the working labor in health in sufficient amount in order to change the assistance model. The availability of professionals in health in the region is very different among the countries, and in the countryside we can see great gaps with a reduction of availability in specific regions and in zones that are very unfavored and very far away. This table shows the number of doctors by each 1,000 inhabitants, and you can see that some countries have reached sufficient number of doctors, for example, Argentina or Uruguay. However, in other countries, we have a great important lack, for example, in Bolivia or Guatemala. A problem that affects the availability of these countries is the immigration of professionals, many of doctors and nurses, to countries that are more developed, that require international agreements and international regulation. The health services are centered in the professional work, and their capacitation is crucial for the quality of the attention. The new demands of individual and collective level require very well skilled professionals. We have to have multidisciplinary teams with new abilities in the individual care and for collective action with transference of tasks of doctors to other professionals. For example, for the nurse personnel and new technicians in primary attention, and also the training of community agents in health. We also have to incorporate support teams like physiotherapists and professional mental health and social workers. For these challenges in this capacitation, it is necessary that this requirements in health be shared by the ministries of health. The training has to be shared between the Ministry of Health and the Ministry of Education. We can observe a lack of GPs to act in the primary attention, and in general, the nursing schools traditionally train for hospital attention and not for APS. It is necessary to develop strategies to train, to have as an axis the training for primary attention and the priority in family medicine and community medicine. The medical training for GPs of quality implies in long processes. For example, in the European Union, the training has a duration of 5 years. However, we can observe a great number of initiatives in the region in the training for public attention in health in all the levels: technical, pre-grade, post-grade, continuous professional development. As examples, we have post-graduation for physicians and family medicine and community, and also graduation in integral communitary medicine in Venezuela in cooperation with the Latin American Medicine School in Salvador Allende de Cuba. In this model, based in the training and services in primary attention clinics, academically certified with training in medicine, the young students are residents of the communities where they are working, and they commit themselves to work in the national system after they are graduated. Another challenge that is important to all the systems of health is to improve the quality of the attention to reduce the problems of our societies. The security of our patients more and more a concern that is always increasing. The Medicine Institute of the United States estimates between 44 and 88,000 people die every year in the hospitals due to medical interventions, many times due to a lack of coordination. The primary attention with GP professionals very well graduated, they comply with the first contact attributes with coordination, following people throughout their life, and coordination reduce unnecessary actions and avoid the prejudice provoked by medical intervention. The primary attention has, in this sense, as Juan Hervás says, a function of quaternary prevention. Here, the challenges are to develop strategies to continuously improve the quality of health attention. The improvement in the quality of medical attention implies in multiple interventions sustained during a period of time, with guidelines, implementations to reduce the variety of practices and behaviors that are a very important factor also to increase the expenses in health, and strategies of permanent education, feedback, auditings, evaluation of performance, professional valorization, and also strengthening the professionalism and professional ethics. Another challenge are the technological changes that impose challenges and also new possibilities at the same time. The development of the ICTs with clinical registries, electronic originating new database that can guide public health actions in the population, facilitate communications, improve information continuity, and the quality of the attention, making it possible, for example, telehealth that increases the resolution of first-level services and facilitates, according to opinion, continuous education that is very important. At the same time, new technologies multiply interventions and transfer hospital actions for the ambulatory attention, incorporation of new technologies and inputs without a previous assessment interfere in the quality and in the expenses in health. Therefore, technologies could be adopted without a positive impact in the health of the patients and even less in the health of the population. And diagnosis approved can be incorporated without resulting in changes in the treatments. This is a field of economical interests that are very strong. In general, studies of incorporation of technologies are funded by pharmaceutical industry of inputs and equipment and must be always analyzed with caution. there is a trend that we can observe, creation of government bodies with the attribution of assessing health technologies, have analysis of cost effectiveness, and develop clinical guidelines to incorporate these new technologies. For example, NICE in England. The assessment of health technology is very costly, and here it's a field where solidarity and cooperation and joint initiatives among the governments is very important, multiplying, for example, similar experiences like the Regulating Center of Medication of ALBA. To advance in the universal access, we have to exercise and amplify the monopsonic power of the governments through regional alliances among the countries for joint procurement, increasing negotiation power regarding pharmaceutical companies and medical equipment. These are only some, and very briefly, some of the challenges of the actual times of the health systems to face our deep load of diseases that compose with infectious, contagious diseases and chronic non-communicable diseases, and also the problems of violence that are always present in many of our countries. The food security is only one of the determinants of health. The ministries of health must disseminate health in all their policies. They must be at the front of intersectorial actions to promote health in the social health determinants. For example, food security with regulation, the establishment of commitments with the food industry to reduce salt, sugar, and fat. This is also a field where we can deepen international cooperation and deepen mechanisms that already exist in global and regional cooperation proposed for the prevention of chronic diseases, non-communicable ones. It is necessary to promote the participation on the systems of health, strengthening democracy, and consolidating solidarity values. All these challenges demand the strengthening of the capability of the regulation of the state. These challenges are faced by different ways depending on the political context with their institutions, players, interest conflicts, economical context, social and cultural ones of each country. Studies of the health systems in compared perspective show some convergencies in the health reforms in the last decades, but also some differences. A same measure of reform has different paths in each country, conditioned by the social-political context and historical legacy. These are complex processes of long-term that require a social base building of support and sharing solidarity values. As Amartya Sen says, to understand health as a human right is a call for action and advice for political, social, scientific, cultural actions to advance in the cause of health for all. To recognize health as a right is to recognize the necessity of a great agreement, socially speaking, for a good health. I invite you all to analyze these challenges in the context of your countries and to think in strategies to cooperate internationally speaking in the joint action of the countries in order to strengthen our national health systems and advance in the assurance of the universal right to health of our citizens. Thank you very much.